Stress and Coping, Module 31. When I get done with this module, there'll be a very, very, very brief recording on pharmacology related to stress and coping, which will be tested in this course. Last year I tried to blend it or mix it over to pharm, and I don't think that worked real well, so we're going to do it right in here as we cover it. Starts on page 2048. Stress is the body's general, non-specific response to demands. Homeostasis is we want to maintain everything at an even keel. Stress can be good or bad. If it disrupts our equilibrium, that's when it's a problem. It can be physical, mental, or emotional. An event is a stressor creates a change in a person or a person's circumstance. Eustress, right here, is a good stress. It prompts you to go on and beat it. Distress is a bad one associated with inadequacy, insecurity, and loss. Stress-related diseases are diseases of adaptation, our body, hurting our body. Stress response, let's see here. Stress response and stress reaction. This is all on page 2048. Allostasis, changes necessary to achieve the characteristics of homeostasis. Our sympathetic nervous system fight or flight kicks in, giving that all our activation of our endocrine system to our target organs. Stress mediators, the glucocorticoids and catecholamines come in and promote our body's adaptation. Allostasis, allostatic load, is a physical cost of adaptation to physiological or psychological stresses. This is just a really good picture. You have the stressors: stop, take a breath, observe, open, proceed, and adaptation. Some stress can be energizing. Allostatic load is when the body systems achieve a kind of balance, but everything is working too hard and it starts to break down. It's just a good picture of everything. It's listed here on page 2048 in your text. Body's response to stressors. We have your changes necessary. So your sympathetic nervous system is kicking in. Your brain gets more alert. Your adrenal gland is, all of these hormones are being released. Your adrenal cortex, that's the little, where the hat, I call your adrenal glands the hat that the kidney's wearing. So they're kicking in your corticosteroids, giving you more energy, your fight or flight, your heart rate's going up, your eyes are dilating, your thyroid's getting more active for your energy. So types of stressors, there is a box on page box 31.1 on 2049. Biogenic and psychosocial. Biogenic stressors, caffeine, amphetamines, illness directly trigger the stress response without any cognitive process. Biogenic. Psychosocial, they can be real or imagined. It's an environmental event, perceived or cognitive appraisal. You know it's there. Fight or flight. Both severity and length of exposure is our stress response. For both a biogenic or psychosocial, the longer it goes on, we can no longer adapt. Anticipation of a stressor can produce the same physiological response of an actual stressor. Stressors can be daily hassles, internal, environmental. This is just a really good picture of some of the things. and it affects our coping process. They can be acute and time limited. There's table 31.1 on page 2049. Acute and time limited, such as an ankle sprain, nursing licensure exam, which you guys will be facing this time next year. Sequential events following an initial stressor, losing a job and subsequently filing for bankruptcy. Chronic intermittent strained relationships with in-laws, shared caregivers of an elderly patient, chronic permanent paralysis, disability, blindness. So you have your box 31.1 on the bottom of 2049, talks about the daily hassles of neighbors, work, paying bills, just life. And then you have internal stressors, internal environment, person's physical, spiritual, cognitive, emotional, psychological. When internal needs are not met, it's harder for a person to cope with changes in their circumstances. Environmental stress, major cataclysmic changes affecting a large number of people, such as natural disasters, war, floods, such as the pandemic that's going on right now. A perfect example, triggers outside the individual require change or disruption. Positive stressors cause eustress, negative stressors called distress. Stressors may stimulate positive or negative. An event is a stressor if it creates change in a person or the person's circumstances. Okay. Individual factors impacting your ability to cope. Page 2050 in your text. Again, there is a table 31.2 on the bottom. Your genetic predisposition, past experiences of coping with stressors, self-sufficiency, ability to meet your own needs, health and well-being has a lot to do with your ability to deal with things, personal appraisal, how you see it, how you think yourself with your coping mechanisms, history of how you've succeeded before and previous ones. Those are your individual, your environmental factors, and your family support, community support, financial resources, community resources, access to healthcare and education, family appraisal, and social support. It's all just, oh, sorry, I didn't realize I had another slide here where I have all your environmental, family, community, financial, community sources, access to healthcare, family appraisal, and social support. See if there's anything else. No, that's it. Okay, so moving on to your cognitive appraisal. There's a whole long column there on page 2050. A person's exposed to stress appraises the stressor. This is the key factor. That's their cognitive appraisal. So you have your stressor, primary appraisal, your cognitive. Is it a challenge or is it a threat? If it's a challenge, you have potential to grow. If it's a threat, it may lead to harm. So you do a secondary appraisal of potential options. It's a low threat if you have effective options. Ineffective options, it's a high threat, and so that increases your stress level. So your first impression here is it's irrelevant, it has no meaning, effect on the person. Benign, positive demands for change perceived as preserving or enhancing well-being. Stressful viewed as harmful, threatening, or disturbing over here. So you do a secondary appraisal at that point if it's harmful, attempt to predict impact, intensity, duration, necessary coping behavior. Intensity of stress response might seem incongruent with the stressor. Important to understand that each person is unique and the response to stress is going to be different. You get into Maslow's hierarchy of needs. This needs to be met before here, before here, before here, before here. So you move your way up the hierarchy of needs from the lowest to the highest. So the 5 stages at each category. As each category needs is met, the person focuses on the higher need above that. There's individual differences, flexibility with regard to sequencing of hierarchy. Prioritization of needs may vary, especially with mental illness. Effective coping is a learned process. It can be favorable or unfavorable. Coping is a dynamic process. That means it's changing through time. It applies cognition and behavioral measures to handle internal and external demands as the individual perceives them, not as we perceive them. It's integration of environmental and cognitive measures. We use a spiritual cognition of affective and inherent voluntary. Coping is a means to manage or alter the problem causing distress. Effective coping is a learned process. We don't know that already. It's not inherent. When a person can't adapt to stress well to maintain homeostasis, then the functional impairment occurs. Table 31.1, examples of types of coping. You're cognitive, minimize the event, or it's not that bad. It's emotional focused, problem focused. What are my odds of surviving? Avoidance, denial approach, controlling the situation. Then you have your behavioral, physical activity, and then your affective is your feelings toward it. You can read over that chart down there. Okay, social readjustment rating scale, or SRRS. This SRRS is a type of stimulus-based stress model. It talks about the stimulus-based stress model on 2052. Oh, I remember doing these twice in my life a million years ago. I never ever want to do another one because my scores were insane. I thought I might as well just go. Anyway, so you list of 48 life events. Each event has a numerical value, and then you quantify the stress level. With each of these different events, it has a score, and you total your score. This is just an example of stimulus-based stress model. This does not allow for an individual's perception of the event, so I don't like it because it just says because of this, you're going to feel that. I think it's a bad example. Some others are your, let's see here, your response-based stress model I think is better. Stress is the non-specific response of the body to any kind of demand upon it. Stress response has three-stage training called the general adaptation syndrome or gas or stress response. The stress response may be global, generalized, or local. A localized adaptation syndrome, for example, local inflammation or response to a scrape. Alarm reaction is your shock phase, and then you have your stress stage of resistance, stage of exhaustion when you can't cope anymore, which this is in your picture on figure 31.2 to me makes more sense than the other. Transactional model, I'm going to skip over that. I don't care for that one. You can read it. Manifestations of stress. Page 2055 does a good job of having a picture showing the stress response of every system in our body. It's physiological, psychological, cognitive, and we have our defense mechanisms. Physiological result of the stimulation of sympathetic and neuroendocrine systems. Nurse is not exempt. There is a whole section on, we're not exempt from stress, burnout. Physiological, psychological indicators of fear, anxiety, anger, and depression. Cognitive indicators, problem solving, difficulty thinking, processing through. Suppression, defense mechanisms, process of denying unacceptable thoughts. Self-control is ability to restrain. These are our defense mechanisms. And fantasizing, daydreaming, imagining fulfillment. Ego defense is an unconscious psychological process. Table 31.4. Ego defense mechanisms on page 2057. Compensation, covering up for weaknesses. Denial, attempting to screen or ignore unaccepted realities by refusing to acknowledge them. Displacement, transferring or discharging emotional reactions from one object to another. An example of that would be a husband and wife are fighting and the husband becomes so angry he hits the door instead of his wife. Displacement. Identification, attempting to manage anxiety by imitating the behavior of someone else. A student nurse imitates the nurturing behavior she observes in one of her instructors. It helps them avoid self-devaluation, feeling useless. Intellectualization, evading the emotional response normally would accompany it. Example is the pain over a patient's sudden death is reduced by saying he wouldn't have wanted to be disabled. So look over your compensation, denial, displacement, identification, intellectualization. Minimization, not acknowledging the significance of one's behavior. Don't believe everything my wife tells you. I wasn't so drunk I couldn't drive. You'll see that a lot when we get into the addiction. Projection, we covered those a lot in our personality disorders. Regression, we've talked about that in loss with children of different ages, regressing, going backwards, or even an adult could do it. Example here, throwing a temper tantrum. Repression is suppressing those thoughts. Unconscious, threatening thoughts and feelings are kept from becoming conscious. Substitution, replacing highly valued, unaccepted with a woman wants to marry a man exactly like her dead father and settles for someone who looks a bit like him. So your compensation, denial, displacement, identification, intellectualization, minimization, projection, rationalization, regression, repression, substitution. Look at some of those examples so you can identify those. Risk factors. Page 2060. This is for altered stress. Genetic considerations. Women are twice as likely as men to develop anxiety disorders. Women, it may be hormonal, women not more susceptible for every type of anxiety disorder, like OCD and social anxiety equally among men and women. Genetic factors, anxiety disorders tend to run in families. Many children develop fears and anxiety similar to those of their parents. Life experiences, exposure to trauma or significant event can trigger anxiety disorders. And if they're genetically susceptible, they're more likely to develop that. A history of spousal or child abuse, being bullied, are life experiences that can do that. Personality-related characters, like shy children, are more likely at higher risk to develop anxiety disorders. Patient teaching in 2061. Exercise, improved cardiac pulmonary function, enhanced muscle tone, weight control, emotionally, tension release, stress reduction, enhanced sense of well-being, sleep rest patterns, physical healing and restoration, cognitive function, sleep hygiene. Nutrition, having a balanced, healthy diet, time management, balancing out the good and the bad, the work and the relaxation, boundary setting. Boundary setting is a huge teaching to do. Listed there in your patient teaching on the top of page 2061 of the 5 areas I just mentioned. just not crazy about the transactional model, but they've got a thing down there on the bottom, 2031. Okay. I mean 2061, excuse me. Stress assessment, it's behavioral, cognitive, emotional, physical. Box 31.3, it's on the top of page 2062. So samples here of your behavioral stress assessment: always doing too much, argumentative, grinds teeth, loud pacing, talks too fast, withdrawn. These are behavioral signs. Your cognitive signs: ambivalence, can't make up their mind, fear of the unknown, forgetful, lack of initiative, lack of sense of humor, short attention span, trouble thinking, want to run away, worrying. Your emotional: agitation, anxiety, crying, fear, hostility, irritability, sadness, suspicion. And your physical: constipation, diaphoresis, dry mouth, fatigue, headaches, increased respiratory rate, insomnia, pallor, racing, pounding heart, restless, shaking, sweaty palms, urinary frequency. You may have recognized some of these from the what you did in the first module there on doing the assessment, mental health assessment. Some others: fingernail biting and cutting, are behavioral. If they're using a cognitive coping, you may not see these physical signs. That's why it's important to ask and assess for all these different things, because they may use different coping skills in dealing with their stress. Independent interventions: what can be done right now, right away, by the nurse? These are listed on 2063. Some things: relaxations, support groups, validating the patient's feelings, reinforcing positive coping efforts, hope and reassurance, not false hope, identifying the stressors in life, helping talk them through different things. Collaborative therapies or psychotherapy, cognitive and pharmacological, and I'm going to go into the pharmacological after this unit. Box 31.4 goes into some cognitive behavior therapy, CBT. Thought stopping is interesting. Behavioral contracts, we've talked about behavioral contracts in some other modules. Comprehensive assessive, you're doing their behavioral area, affective component, physical component. So the assessment in mental health is multi-layered. Thought stopping is a technique that's used to help the patient change her thinking process. And then the behavioral contract is also used a lot for suicidal ideation. Just a slide, on your pharmacological. I'm not going to go into here because I decided it was better for me to make a little separate recording with some slides where we're going to go over those in more detail. Lifespan considerations. Starts in 2068, goes into 2067, but you have this great little box, 31-5 on the bottom of 2066, which helps because it's developmental again. The signs in children, adolescents, and adults. Non-normative stresses in children can become toxic if the child or adolescent does not receive the adult support they need. They can really damage them. Children will display irritability, withdrawal, clinging, new recurring fears, feeling ill frequently, changes in eating, bedwetting. Abdominal pain is a biggie with that. Adolescents, excessive tiredness, anger, defiance, substance abuse, criminal activities, withdrawing from school, dropping grades. Older adults, sleep pattern, eating habits, poor judgment, more likely to have physical complaints. Let's see here on latchkey children. No, I'm not going to go into that. But here on your box, multiple things: adults, developmental stressors, things that can cause the stressors at the different periods of their life. Disorders related to stress, we have anxiety disorders, obsessive compulsive, trauma, and stress disorders, which are all these different modules, which I'm going to break down here. So we're going into your anxiety disorders. Exemplar A is on page 2069, really 2070. Most common mental illness in the United States, no clear biological or environmental cause. Several theories are based on this. It's response in anticipation of perceived or actual threat to oneself or significant relationship, characterized by feelings of mental uneasiness, apprehension, dread, foreboding, feelings of helplessness. I'm sure everybody has experienced anxiety at some point, but this is when it becomes a major, oops, I should have been on this slide, major risk. Sorry about that, didn't realize it had gone 2 slides. So that's anxiety, but it's a disorder when it is into stress or fear during everyday situations. So we all experience anxiety, but when it becomes an everyday feeling in everyday situations, it affects about 20% of the population. Actually, I wouldn't be surprised if it's actually higher than that. Right now, during this pandemic, it is huge. The theories are chemical, psychosocial, behavioral, genetic, humanistic, multiple different theories, which I'm not going to go into. I don't think that's pertinent. Risk factors, childhood adversity, including witnessing traumatic events, not necessarily have experienced it. They don't have to experience it themselves. 2071. Family history of anxiety disorders puts them greatly at risk. Social factors such as lack of social connectedness, serious or chronic illness, traumatic events, personality factors such as shyness or worrying puts them more at risk. Multiple stressors such as chronic illness, concern with loss of employment. Some preventive factors are keeping a journal to catalog stressors. If multiple risk factors, avoid unhealthy substance use. So more preventive measures, avoid unhealthy substance use and journaling. Clinical manifestations of general anxiety disorders is listed on page 2075. You have mild, moderate, severe, and panic. You're mild, sleepless, more alert, increased motivation, and can be with behavior, massage, aromatherapy, sleep hygiene. When they get to the moderate level, self-absorption, increased respirations and heart rate, rapid speech, reduction in alertness, cognitive behavior therapy, maybe some low-dose medications, and some other things such as yoga, massage. Severe difficulty following directions, feelings of doom, headache, dizziness, palpitations, tachycardia. They need cognitive behavior therapy, learning coping skills, anti-anxiety medications, relaxation techniques, other integrative therapies, and may possibly need hospitalization. Panic is inability to focus, terror, feelings of doom, dilated pupils, trembling, immediate structured intervention, pulling them out of the stimulating environment to a less stimulating environment, use of repetitive physical tasks, giving them something, stacking things to help with that anxiety level, long-term therapy, cognitive behavior therapy, medications, relaxation techniques, working on sleep hygiene, acupuncture, nutrition, mental health counseling. want you to look over on page 2078. There's table 31.6-6, symptoms of anxiety in children and adolescents, because they are going to display differently because of their emotional, developmental, cognitive ability. Both children and adolescents, excessive worrying, headache, stomachache. That's what I mentioned before. Stomach aches is huge. Symptoms common in children: frequent missing school, tiredness, restless, irritability, trouble sleeping, being very shy, frequent crying. Symptoms common in adolescents: withdrawn from social activities, dependency, performing poor in school, easily startled, impulsive sexual behavior. They also have depression or an eating disorder, suicidal ideation, self-injury, cutting, frequent need to urinate. So, and your older adults' manifestations is listed on page 2079. Anxiety in older adults. They already have a cognitive impairment, some physical impairments, so they're at higher risk for developing anxiety. Especially after so many losses or a significant loss. And they have a difference in their drug absorption and metabolism, so they're more likely to have adverse effects when they're given medications. Benzodiazepines should be avoided in the older population because of the harmful side effects such as decreased cognition. Older adults may find that cognitive behavior therapy is more effective for managing their anxiety. Let's go on. General anxiety disorder, GAD, back on page 2072. This is your summary criteria on the bottom, table 31-5, bottom of 2073. Yeah, 2073. Am I in the right place? Oops, wrong page of my text. Okay. Excessive general anxiety disorder is excessive worrying out of proportion of the stressors, whether it's perceived or actual, and it interferes with their daily activities. Highest risk is in early adulthood. Intense worry. Effective individuals usually recognize their anxiety is disproportional, but they cannot control it. Often somatic symptoms of fatigue, headache, muscle aches. Okay, so now that's your general anxiety disorder. Your panic disorder, which is listed next in table 31.5, sudden attacks of terror, sometimes with a pounding heart, sweating, panting, dizziness, twice as common in women than in men. It's recurrent when at least one of the attacks has been followed by 1 month of persistent concern about having more attacks. This is a panic disorder, just not a panic attack. The attacks are not due to physiological effects of a substance. The attacks are not better accounted for by any other mental disorder. Those have to be ruled out. And then you have your specific phobias, agoraphobia, social anxiety disorder. Their intense or extreme fear of a particular object or situation, whether it's spiders, snakes, flying, or heights. Agoraphobia is anxiety associated with 2 or more of the following: enclosed spaces or open spaces, using public transportation, being in a crowd, or standing in a line. Social anxiety disorder is pervasive, extreme fear of social situations that they're going to be scrutinized. Symptoms must last at least 6 months for a patient, regardless of their age, to be considered a phobia. So those are some of your keys there. So your general anxiety disorder, excessive anxiety, had everyday problems for at least 6 months. Your panic disorder, recurrent unexpected panic attacks, at least 1, followed by a month of persistent concern, and your phobia symptoms must last at least 6 months. I Again, the pharmacological in 2076, I'm going to cover in a separate blurb after this. We're going to go into your non-pharmacological therapy. Mostly that's on page 2077, cognitive behavior therapy, herbal preparations, massage and therapeutic touch, relaxation techniques, yoga, meditation. Interventions, mild, often able to learn new behaviors, moderate, prevent escalation, adhere to their treatment plan, severe, clear and simple direction, may need to be hospitalized, moderate sometimes will have to be, panic, safety and reduce their stimuli, pull them out of their situation. Patient teaching safety is a biggie. So your patient teaching on 2081, techniques to reduce anxiety, look at that on the bottom of 2081. And then there's some just implementation. I'm not going to go over your anxiety, your planning. These are the goals you have for them. Implementation, provide, the nurse is able to provide valuable information to these patients, how to recognize their triggers, improve their motivation and learning, self-management and diversion techniques for coping with anxiety, like exercising, engaging in hobbies, spending time with family and friends, positive self-talk, use of muscle relaxation and mental visualization. That's where I tell people, find your happy place. That's what I call it. Taking medications as prescribed and knowing it takes several weeks to be effective. Psychotherapy, cognitive behavior therapy to reduce the anxiety symptoms, community resources such as support groups, message boards, and goes in there for your moderate and severe, and panic. I think I've really covered those already. Okay, so we're going to move right along into Module 31B of crisis. A crisis is an acute situation. It could be situational, maturational, and resilience. Situational, unexpected stressor or circumstance like a tornado or death. Maturational, predictable stages of human development. And resilience, adapting well in the face of adversity, crisis. Okay. The event will resolve when the situation goes away as we grow past it, and resilience, we develop a resilience as we go through things and we find ways of coping, and we use those when others come around us, other situations come about. Common clinical symptoms, page 2086, on the top of 2086, difficulty problem solving, disorientation, vulnerability, hypervigilance, that's very aware, disorganized thoughts, vulnerability, disorientation, intense emotional reactions, intense physical reactions depicted in fight or flight response. So your etiology could be any of the things listed there. Counseling, crisis intervention, may need intense counseling and or inpatient hospitalization, group, family, individual therapy, pharmacological things that we will talk about. See diversity and culture differences. That's expression of emotion, can be a cultural concept, on the bottom of page 2086. See if I have anything else. 31.6, 31.7, 31.7, communicating painful information box, 31.7, that's on page 2087. One of the uncomfortable roles of the nurse is to communicate painful information. The task can be unnerving. This is just giving you, greet the individual with warmth, inform them that you are there and will assist during the difficult time. Privacy is important. Inquire what they know and answer the questions. Apprise them of current situation. Respond to their feelings with support. Ask what they need from you. Incorporate cultural, religious. Inform them. You will facilitate communication. Focus on immediate reaction. Write down specific contact numbers and instructions. Check back with them as needed. That's a very important common role for a nurse in many situations, no matter where you're working. Therapeutic communication in crisis, box 31-6, verbal and nonverbal communication, maintaining eye contact. Paraphrase and repeat the patient's statements back to them. I hear you saying, or tell me what that means. Avoid making statements or comments that invalidate their judgment, or that doesn't sound right, or don't ever say things like that. Although encouraging the expression of emotions is important when appropriate, silence is also an effective communicator. Six, I think I just covered that. Box 31-6 on your therapeutic communication, crisis counseling, crisis intervention. I like this, the ABC of crisis intervention: achieve rapport, boil down the problem, cope with the problem. A, B, C. Found on box 31-8 on page 2088. Achieve rapport, boil down the problem, identify, validate, intervene, and cope with the problem. Come up with a resolution and a referral. Note, pregnant women, page 2090, safe and calming environment to express fears and concerns. Where's this 2090? Oh, with pregnant women in crisis. Nurses can provide a safe and calming environment which a pregnant woman can express her fears. Nurses should validate the pregnant woman's emotions, provide with information about specific to their situation. Like she may have been told she's going to have a child with Down syndrome. Give them literature on what to expect, or who are pregnant as a result of rape. The nurse can encourage the woman to work through. Anyway, okay, multiple things there. 31, I think I covered all these. Box 31-9. Oh, that's on the bottom of 2089. Crisis connection. Make contact and connect with the individual. Assess immediate safety needs. Safety. Determine their thought process. Scan for physical distress. Listen intently. Support emotional reactions. Explore perceptions of the crisis. Identify coping strengths. Develop a support plan and follow-up plan. Your whole nursing process is ADPIE, A-D-P-I-E. Note, even if a family, each individual copes and responds differently. They may look like they're helping each other, but each individual has their own way to do this, and you need to allow them, encourage them to be able to work their way through all of this. So assess, diagnose, plan. There's a list of some possible diagnoses there, 2091. So you're doing a family assessment, plus you need to do individual assessments within that family. Oh, nope. Implementation. Multiple things on your implementation. Reducing the risk for injury. This is 2092. Identify risk factors for injuries. The home environment may include fixing stairs, installing lights, moving weapons. Monitor patient's community for ongoing threats. Isolate the patients from any potential source of injury. If they're a risk for self-injury, move any potential weapons. If the patient is in a hospital environment, also make sure that they are safe and remove what you need to. Safety alert. Nurses need to be constantly aware of the potential dangers and risks for injury involved in responding to a patient in crisis. These threats may come from the environment. If it's a natural disaster or community crisis, it may come from other people involved in the crisis or even the patient themselves. Nurses must be careful to ensure that in responding to a crisis, they're aware of the possibility of becoming overwhelmingly psychologically, emotionally, physical themselves, and are no longer able to be effective. So, decreasing anxiety. Number 2, anxiety may accompany the patient's feeling of being overwhelmed in this crisis. We covered anxiety in exemplar A. Promoting self-care, they gave some tips here. Monitor signs of self-neglect. Encourage family and friends to help with home responsibilities like childcare. Make sure they're eating and hydration, maybe getting meals on wheels. Help patients research family leave, vacation, or other resources in the hospital setting. Encourage patients to follow routines of self-care. Promoting effective coping, providing information about community resources for housing, clothing, transportation, jobs, food. Present a calm and collected demeanor to the patient. Anxiety is contagious, but so is the calmness. Removing the patient from or patient's family from visual reminders of the crisis can be helpful. Encourage the patient or patient's family members to drink water and eat small amounts. The nurse may need to encourage family members of the hospitalized patient to go home and rest. Contacting next of kin for them, providing patients or family members with small, simple tasks to make sure they feel needed. Keeping them updated of everything. So decreasing acute confusion, providing orienting information, providing written instructions, that's really important. Helping patients remember who they are with IDs, repeating information, and then meet the needs in the assessment, avoid minimizing the patient's feeling. And your safety alert on page 2092. I covered your safety alert. Patient teaching on 2093, benefits of support groups, empowerment, improving your coping skills, freedom to speak openly and honestly, reduction of feelings of distress, better understanding of their situation, and diversity in the group, and comparison of notes on dealing with things. 31C, the last in this section for stress and coping, is obsessive compulsive disorder. Starts on page 2095. This is a disabling disorder. They have obsessive thoughts. It's not an obsessive compulsive tendencies, it's an actual disorder. Repetitive compulsive behavior involves several areas of the brain, several neurochemicals are involved. The etiology typically begins in adolescence or early adulthood, presents earlier in males, and then as they get older, it presents equally in males and females. Highest risk is first degree relative with it and traumatic event in childhood. Had it youngest I saw, I think was 11 when he was diagnosed. His mother had obsessive compulsive disorder, really impairing. She had been married. The marriage was traumatic. The child witnessed that, and he was demonstrating this disorder, Bale, very, very, very young. Females tend to be more about age 25 before they present. Okay, next slide. Clinical manifestations, obsessions, aggressive symmetry, contamination. Symmetry is a big one. So if you look at your clinical manifestations on page 2097, aggressiveness, sexual religious obsession, checking compulsions, checking doors and locks, confesses frequently to anything, needs to ask others repeatedly for assurance. There's some medications which I'm going to cover separately. Cognitive behavior therapy, sometimes they add antipsychotics. Symmetry, needs to have objects in a fixed symmetrical position. They repeat movements such as going in and out of doorways, getting in and out of chairs, touching objects, counterspell things silently or out loud. It's this compulsion, obsessive compulsive disorder. They are not cognitively aware of this. Obsessive compulsive tendencies, they know and it's interfering, but the disorder, they are not able to distinguish that this is contamination. Oh, I've seen that. They're obsessively washing their hands, cleaning compulsions, repeatedly doing it, showers, baths, brushing teeth, clean personal space. Lifespan considerations. I think I covered that a little bit. Mean age, 7.5. Usually that's in males. Females usually age 25. Peaks in prepubescent and again early in adulthood. Rage attacks in children. So normally it is often missed in children, and the male may be noticed earlier, and females usually in their 20s. Often subclinical in older adults, where it's not so evident. And with the older adult, they tend to have many other things, comorbidities, that make it very difficult to to diagnose. Rage attacks is when the family accommodates for the OCD behaviors. So I'm going to back up here. Symptoms of OCD in children are often hidden or ill-defined and missed. Younger children in particular are not able to articulate their fears. Obsession and compulsions are often similar to those experienced by adults, but they change over time. Often related to sensory stimuli, tactile, musculoskeletal, auditory, visual sensations. Children and adolescents more likely for these rage attacks in relation to their OCD. This is a phenomenon enhanced if their family accommodates or reinforces their OCD behaviors. Development of OCD in some children may be linked to streptococcal infection, which is interesting. Initially referred to by this acronym, I'm not going to worry about it. But cause of this form of OCD appears to be antibodies mistakenly attacking a gene of the region of the brain. Another major risk factor for development of OCD is association with the first disorder relative, but following a strep infection. Interesting. Okay, what else? That is it on that one. So let's go into implementation. Alleviate their fears, supportive and non-judgmental. Do not interrupt the rituals that will lead to a rage. Coping, promote effective coping, a calm presence, reduce environmental stimuli, avoid triggers when you've identified those. Promote effective role performance, patient to describe the normal roles, not competing due to disorder. Social rituals interference, a list of friend and family support. Let's see here. Page 2090. Effective role performance. Encourage patient to have healthy conversation with their family members about the disorder. Have the patient describe their normal roles that they're not able to perform. And discover why. Promoting self-awareness for the patient to understand their reaction to their environment, and encourage the patient to participate in individual and family therapy. Safety alert. Patients who perform excessive washing rituals are high risk for impaired tissue integrity. Teach the patient about consequences of excessive hand washing, and include regular use of lotions. Promote social interaction. OCD spend hours each day performing the rituals. Friends may avoid spending time with the patient because of their odd behaviors. As patients progress through treatment, nurses can promote their social interaction by teaching time management techniques. Plan to arrive at social events on time. Open with their friends about the disorder. Encourage the patient to invite close friends and family to a counseling session. And the evaluation, patients with OCD have a low rate of successful response. About 50% improve, but only 10% recover completely, which is sad. The patient verbalizes a reduction in anxiety associated with compulsive need to perform these behaviors. Okay, so that is finally the end of this recording.